Well, welcome everyone, and thank you for joining us for the International Myeloma Foundation's Living Well webinar series. And today we will focus on understanding Medicare changes in 2024 and beyond. So I'm Robin Toohey, Vice President Support Groups at the International Myeloma Foundation. Before we get started, and on behalf of the IMF, I'd like to thank our sponsors for supporting this educational program, and they are Bristol Myers Squibb, Johnson & Johnson, Karyopharm Therapeutics, and Sanofi. We will have a video replay available on the IMF website along with the speaker slides. This is a great way to review the material, and if you belong to a support group, something that you can replay at your meetings. You can find this replay and all other IMF webinar replays on myeloma.org, and on that top bar, if you click on videos, that's where you'll find them. And here's how you can ask your important questions. Simply open the Q&A window and type in your question. We will do our best to get to all of these questions. I know you're going to have a lot of good engagement today. However, if we don't happen to get to your question, don't forget you have the IMF info line to help you, and you can reach them at 1-800-452-CURE, which is 2873. Or you can reach them by email at infoline@myeloma.org. It is really important for us to hear from you. And at the end of today's webinar, you'll have the opportunity to provide us with your feedback. We truly value this, and it's the only way that we can move forward and continue to provide you with these valuable resources. Oh, there we go. So I'm really excited about this slide, and I hope you are too. March is Myeloma Action Month. And this year for Myeloma Action Month, the IMF has been engaged. And so far we've reached, drum roll please, 33 million people globally. That is amazing. And the goal, of course, is to help people know what is this word, multiple myeloma, and what are the signs and what are the symptoms. And everyone's stories mattered, and we thank you for your engagement. And we have a couple more days, so keep up the good work, and together we'll ensure that myeloma awareness increases globally. So now it's my pleasure to introduce you to our first speaker, and that is Danielle Doheny. Danielle is the IMF Director of U.S. Policy and Advocacy, who's going to provide a brief overview on how the IMF advocates for bills like the Inflation Reduction Act. And then following Danielle's introduction, we'll hear from Joanna Fawzy Doran from Triage Cancer. She is a cancer rights attorney and CEO of Triage Cancer, and she's going to go into details on understanding Medicare changes in 2024 and beyond. So how in the real world are these changes affecting us? So Danielle, if you would be so kind to begin, please.
Sure. Thanks so much, Robin, and thank you everyone for being here today. I'm Danielle Doheny, the Director of Public Policy and Advocacy at the IMF, and I'm truly excited about our program today because we'll be discussing a lot of significant changes coming to Medicare, and understanding these changes is crucial for our community. So I'm absolutely thrilled to have Joanna here. I had the opportunity to hear her speak in the past, and she has an absolutely remarkable talent for breaking down really complex information and explaining how it will affect real people. And I'm truly confident that her insights will be so valuable to our patient community and really anybody on Medicare. So before we begin learning about these changes and how they'll impact patients, I'm just going to give you a really brief overview of how we advocate for changes like this, and just a little bit about what went into ensuring that this particular change would be beneficial to myeloma patients. So on this slide, you'll kind of see a little bit of how we do things. As you may know, Congress functions like a response-driven body. So you have to go in and ask for things, basically, or it's not going to move. So there's nothing more impactful than having public health experts, patients, caregivers come meet with lawmakers about important issues. I've been on the other side of this before as a congressional staffer, and really hearing those personal. Can you hear me? Okay, thank you. We have a pretty bad rainstorm here today, so I'm thinking maybe something with the internet. Apologies, everyone. So as I was just saying, advocates are key to helping politicians understand any issue and really motivate them to take action. They're not going to do anything if they don't hear from the people back home. So thanks to these efforts, we've seen better funding for things like health research, better health coverage, and just faster responses to big public health problems. Even, for example, the COVID pandemic, we've seen positive changes from advocates like advocates like those at the IMF and other organizations. So, did I miss? There we go. Apologies, I think. There we go. My slides are all messed up. So when we say inform and influence decision makers when it comes to these critical issues that affect patients, and I think a lot of people ask, well, what's that even mean? And how do you do it? And I just wanted to break it down a little bit. So policy making was really just laws, regulations, actions, anything that'll be implemented in society to promote health and wellness and ensure our health system works. So here's just a little bit about how we do things and how things work. So first and foremost, we monitor and analyze. So we'll keep an eye out for policy issues or opportunities where we could interject our views and impact myeloma patients positively. So this could be something from like an existing law, something being implemented, or so something new being proposed. Policy making is just always constantly changing, and we need to stay up to date. So a lot of it's just monitoring and seeing and analyzing. That's step one. Step two is engaging and educating. So we build relationships with policymakers, whether that's relationships that I have or other IMF staff have, or even patients who like to engage. So we have those relationships, and then we'll explain to those legislators or their staff members how these policies affect patients like you. So it's important for us to put some groundwork down for support long before a crisis hits. So we don't want to be coming to them and them not even knowing who we are, not knowing anything about us. We want them to kind of view us already as someone they can rely on. So we want to make sure policymakers truly understand our concerns before anything becomes a big issue. And we also advocate. We speak directly and lobby for specific policy changes, all levels of government for that. So we do have some people we call like a congressional champion. That'll be somebody we go to often, and we also try to talk to everyone. We want to make sure everybody knows about what we want. So one thing that I'd like to highlight, that the IMF doesn't do this alone. We have so many partners to make sure that policymakers understand what patients and caregivers need. It's a coordinated effort to move common goals forward. So that can be organizations like Joanna's, or organizations, maybe not even cancer related. We work with basically any disease you can think of has a department like ours and works on similar issues. So a lot of those access issues are similar. And our expertise in this work really just means we understand the political system, how laws are made, and a lot about the healthcare system. But we depend on patients to have that patient experience and for folks to tell us what they need. So we advocate for things just like timely diagnosis, better treatments, funding, and research on Capitol Hill. And in short, our job is just to make sure policymakers hear the patient voice and understand how any decision they make affects the health and well-being of a myeloma patient or their family members. And I think while we're on this topic, it's just important for you guys to know a little bit about what we have been advocating for this most recently. So some of our priorities in 2024 include increased federal research for myeloma. That's something that's constantly, every year we have to go advocate. So something that's always on our agenda, enhancing access to and diversifying clinical trial participation. That's everything from making sure that the trials are diverse to making sure people in rural areas can participate. We want anybody who wants to be able to participate in a trial to be able to do so. And also, one very important area is insurance reform for private insurance. For example, oral parity laws. That's making sure that the administered therapies and IV therapies are both affordable to patients. A lot of myeloma patients take these oral therapies, and it's very important to us to make sure that that's something that is affordable to you. Something called copay accumulators, making sure that any copay assistance you receive benefits you and not your insurance company, improving step therapy protocols, so ensuring every patient has access to timely and effective treatment prescribed to their doctors, no unnecessary delays. And lastly, just ensuring that access to emerging therapies are available. We talk with our doctors and anybody who might know of what might be to come. So people who have experience with drugs coming to market. So that would be like things like CAR T cell therapies, bispecifics, things that may have different challenges than the drugs that are already there. So we're forward thinking as well. And lastly, the implementation of the Inflation Reduction Act is one thing that we've been focusing on. Just to share a little bit about myself, my father's a 12-year myeloma patient. And unfortunately, like so many of you, my family and I, we know how stressful it can be from a financial aspect on a patient and their families. Often entire families are involved in the process of trying to figure out where the open assistance funds are, and like just learning what your loved one might qualify for and where the help is. We put another plug in for the IMF info line. They've been so helpful to my family. But as you saw in that previous slide, there are so many ideas that have been tossed around when it comes to advocating for patients with private insurance. And for several years when I came to the IMF, the question was, what can we do for Medicare patients? Something has to be done. We have all these ideas to help people with private insurance, but Medicare patients are struggling too, and quite a bit when it comes to the access thing. So it was just so clear that something needed to be done. Luckily, the community came together and just discussed some of the changes that might benefit our patients. We ended up going and advocating for these changes together. And Joanna will soon be covering some of those positive changes and how to navigate them. But we're also in the midst of the implementation stage. So right now, we're closely collaborating with our fellow advocates, most of whom are involved in the bill's passage. So these efforts just extend so far beyond cancer. Advocates from various disease communities. We've been on calls, chats, everything, going through different pieces of text, doing letters together to different agencies. And these advocates come from everywhere, from arthritis to psoriasis to MS to the cancer community. And we just have all shared our insights and kind of just making sure that patients are able to navigate these changes. So we've all joined forces and we just committed to this cause of increased access and affordability. And I'm really excited about what's to come. And I think Joanna will really do a wonderful job at making these changes understandable and just so much easier to navigate. So I wanted to toss it over to her to talk a little bit more about what those changes are. And we have some resources here before I do so. You can email us at advocacy@myeloma.org if you have any ideas about changes. We're happy to bring them to legislators. And if you just want to subscribe and see what's going on, I have a link here to jump and see our newsletter. So without further ado, I wanted to toss it over to Joanna.
Thanks, Danielle. I certainly hope that today I can help everybody understand a little bit better the changes that are coming to Medicare in 2024 and beyond. But before we jump into Medicare, I actually want to start by just reviewing some of the key insurance terms that I'm going to use today, but also to lay some foundation for how Medicare has changed. So there are costs that we pay to have health insurance coverage, and those costs are referred to as our premiums. We typically pay our premiums on a monthly basis, and it's a fixed dollar amount that we pay each month. So you might pay $300 a month for health insurance coverage. But then there are costs that we pay when we actually get medical care and use our health insurance coverage. And the first cost is our deductible. It's what we pay first before our health insurance coverage kicks in. So it is a fixed dollar amount, and the amount is going to depend on the type of health insurance that you have. You might have a $500 deductible, or you could have a $3,000 deductible. It will depend on your plan. And then there's something called a copayment, and this is also a fixed dollar amount that you pay each time you get medical care. So you might have a $30 copayment to see a primary care physician, or a $50 copayment to see a specialist. The amount, again, is going to depend on your plan. And that's different from coinsurance or cost share. Those are two terms that mean the same thing, and it's a percentage. It's the difference between what insurance companies pay for our medical expenses and what we pay. So if you have an 80-20 cost share, that means your insurance is going to pay for 80% of your expenses and you're responsible for 20%. But the most important thing that anyone should know about their health insurance coverage is their out-of-pocket maximum. Because in a worst case scenario, that's the most that you're going to pay out of pocket for your medical expenses during the year. And it is a fixed dollar amount that will depend on the type of plan that you have. And when you reach that fixed dollar amount, then your insurance kicks in at 100% for the rest of the year. So how you reach your out-of-pocket maximum depends on the plan that you have, but generally it's a math problem. You get to add up what you pay for your deductible, plus any co-payments that you make, plus any co-insurance amounts that you pay to help you reach your out-of-pocket maximum. So to give you an example of how this actually works, I'm going to introduce you to Dan. Dan has a plan that has a $2,000 deductible. It's an 80-20 plan, and he has an $8,000 out-of-pocket maximum. Dan spends a week in the hospital, and he walks out with a $102,000 hospital bill. So assuming he's had no other medical expenses during the year, what does he actually have to pay for that bill? So first, he has to pay his $2,000 deductible, which leaves $100,000 left of that bill. But he has an 80-20 plan. So his insurance is going to pay for 80% of that $100,000, and he's responsible for 20%, which leaves him with a $20,000 bill. But he has an out-of-pocket maximum of $8,000, and he's already paid $2,000 towards his deductible. So he only has to spend another $6,000 of that $20,000 bill, and then he's reached his out-of-pocket maximum. So his insurance will kick in and pick up the rest of that $20,000 bill. Now, I always say I'm not suggesting that $8,000 isn't a lot of money, but at least it provides a cap on what Dan would have to pay out of pocket, where he doesn't have to pay that full $20,000 bill. So it allows us to plan for that worst case scenario when we know the most that we'll have to pay out of pocket for our medical expenses during the year. So turning now to Medicare. Medicare is a federal health insurance program that covers about 20% of people in the United States. So that's 1 in 5 people. So a significant number of people are covered by Medicare, but it only applies to individuals who are US citizens or legal residents and who are 65 years or older and eligible for Social Security retirement benefits, or for someone who's been receiving Social Security disability insurance for 2 full years, or for someone who has end-stage renal disease or ALS. Those are two medical conditions that automatically qualify you for Medicare. But Medicare coverage is actually broken up into different parts. Part A of Medicare is hospital insurance, and it really is just meant to cover hospitalization. So when you're actually hospitalized, Medicare Part A is what's going to pick up your coverage. There is coverage for hospice care as well under Part A, and very limited skilled nursing facility stays or home health care or nursing home stays, but after a hospitalization. So really narrowly focused is the coverage under Part A. And most people who qualify for Medicare get Part A for free because you've paid into the Medicare system. So you don't pay a monthly premium for it. But if you haven't worked and paid into the Medicare system long enough, you can still get Part A, but you do then have to pay a monthly premium. There are also deductibles and copayments for when you are hospitalized that you would need to pay under Part A. Part B, on the other hand, is medical insurance, and it's really the core of Medicare coverage. So it's going to cover things like outpatient visits to the doctor, preventive services, your blood work and imaging scans, durable medical equipment like crutches or wheelchairs. All of those things are covered under Part B. IV chemotherapy is also covered under Part B if you're receiving it in an outpatient setting as well. But Part B isn't free. Part B comes with a monthly premium. And the monthly premium this year for Medicare Part B is $174.70 a month. However, Part B is now tied to your income level. So if you have a higher income level, your Part B premium is actually going to be higher than that. But that's what the base premium is for this year. Part B also has a deductible, so you have to pay $240 first for any of the services that you receive under Part B before Medicare Part B is going to kick in and pick up your expenses. And Medicare Part B is an 80-20 plan. So Medicare Part B will cover 80% of your care under Part B, and you're responsible for 20% out of pocket. And what's incredibly important to know about Part B is that it does not have an out-of-pocket maximum, meaning you're responsible for paying that 20% for care under Part B all year long. So that's one of the downsides to Part B. Medicare Part A and Part B together are what we refer to as original Medicare, because when it was passed in 1965, that's all that existed, was Part A and Part B. And original Medicare is called fee-for-service, meaning that you can go to any provider across the country who accepts Medicare to get care under Part A and Part B. So you're not limited to a network of providers. They just have to accept Medicare. Then that brings us to Medicare Part D, which is prescription drug coverage. But it's structured a little bit differently because Part D plans are separate plans that you have to go and buy from a private insurance company to get that prescription drug coverage. So the cost is going to vary based on the plan that you pick and which company is providing that plan. So this year, the plans can range from $1 a month to $108 a month. Also, what you pay for your Part B premium is tiered based on your income level as well. So you might have the exact same plan as your neighbor, but yours might actually cost you more if you have a higher income level. There's also a standard deductible this year for Part D plans that can't be more than $545. And what you pay for copays and coinsurance is going to depend on your specific plan. I want to talk about the changes to Part D specifically in the Inflation Reduction Act that Danielle mentioned, but in order to talk about where we are and where we're actually headed next year, I want to take a step back and look at Part D coverage before these changes. And actually, prescription drug coverage under Part D was created in 2003 by Congress, but it wasn't actually fully implemented until 2006. So 2006 is the first time we get prescription drug coverage for Medicare. And prior to the Affordable Care Act, I want to show you what a Part D plan looks like. So you all might be familiar with the term, the Part D donut hole. And while many people are familiar with the term, people are less familiar with how it actually worked. So if you go back in time with me to 2009, the year before the Affordable Care Act was signed into law, we have a Medicare Part D plan, the standard plan, where you have a deductible. And in 2009, that was $295 that you had to pay first before your Part D plan kicked in. And then you'd enter what was called the initial coverage phase until your total drug costs cost $2,700. And in this period of time, you had to pay for 25% of your drug costs and Medicare paid 75%. Then you'd enter the donut hole, where Medicare paid $0 for your prescription drug costs, and you were responsible for 100%. So we call this the donut hole because there's nothing in the center. There's no coverage for prescription drugs. That's the hole. And then once your total out-of-pocket drug costs reached $4,350, Medicare would kick back in and pay 95% of your drug costs, and you'd have to pay 5% of your drug costs, or $2.40 for generic drugs and $6 for brand name drugs, whichever was more. So in most cases, when we're talking about cancer-related drugs, 5% is going to be more. So most of the time, someone was paying 5% for their drugs for the rest of the year. So 5% doesn't sound like a lot, but if you have a very expensive drug, 5% of a very expensive drug is a lot of money. And there was no out-of-pocket maximum. So there was no cap on what you would have to pay out of pocket for the remainder of the year. So this is what the donut hole looked like before the Affordable Care Act. Then the ACA stepped in and did some things to improve Medicare coverage by adding a free wellness visit, it added free preventive services, and it lowered the cost of prescription drugs by closing that donut hole. But in true political compromise, it did it over 10 years. So each year from 2010 to 2020, what you paid for your prescription drugs in the donut hole closed a little bit. And eventually what we got in 2020 was that the donut hole closed so that after you paid your deductible, you'd be responsible for 25% of your drugs and Medicare would pay for 75%. And then once you reached a certain number at your total out-of-pocket drug costs, Medicare would pay 95% and you'd pay 5%. But there still wasn't a cap on what you would pay. You'd still be responsible for paying that 5% for the rest of the year. And so then along came the Inflation Reduction Act. And this is what we have as of January 1st of this year, where you are responsible for paying a deductible, which is capped at $545. So the most that you'd be required to pay for your plan is $545 as a deductible. You might have a plan that has a lower deductible. So this is how a standard plan works. Then once you've paid $545, you enter the initial coverage phase where you're responsible for paying 25% of your prescription drug costs. But here's where things get really interesting and where the changes come. You also, in this period of time, will get discounts, 70% of the value of your drugs from the drug company. And then your Part D plan pays for 5% of drug costs during this initial coverage phase. And then when your total out-of-pocket drug costs reach $8,000, then you enter the catastrophic coverage period where you pay $0 and then you don't have any more costs for the rest of the year for your prescription drugs. So we actually get here a true out-of-pocket maximum of $8,000 for the cost of prescription drugs, which we've never had before in Medicare. But this is also where things get a little bit more complicated and where the math has actually been very confusing for us as advocates to figure out, because while your total out-of-pocket drug costs have to reach $8,000, you don't necessarily actually have to spend $8,000 out of pocket. And the reason why is because if you are only taking brand name drugs, you actually get credit for the 70% that the drug companies are paying in discounts to help you reach that $8,000 out-of-pocket maximum. Which means if you do the very complicated math, that your actual out-of-pocket costs would be $3,333. So that's a lot different than $8,000. But what is also confusing about this is that you're hearing a lot of people, especially in the cancer community, saying that the drug costs are capped at $3,333, but that's only if you're taking brand name drugs. If you're taking a generic drug, you're not going to get credit for that 70% drug discount from the pharmaceutical company. And so that means that you may actually then have to pay a full $8,000 out of pocket. So that's a pretty big difference. And I think it has been under discussed in the cancer community. And so it's important for you to understand specifically the drugs that you're taking and how they're going to help you reach the total out-of-pocket drug cost of $8,000. So if you would like to understand the math a little bit more, we did actually write a blog that gives an example and shows the actual math of how we get to $3,333. And the link is here on the slide. But there are a couple things I want to mention about 2025, because in 2025, our out-of-pocket drug costs under a Medicare Part D plan are capped at $2,000. So really what's happening is from 2023, we go from no cap on drug costs in Medicare to this year where we get a maximum of $8,000 out of pocket for drug costs, to next year where regardless of whether or not you're taking brand name or generic drugs, the most that you are going to pay out of pocket for your prescription drugs in 2025 is $2,000. And if you are paying a deductible, the deductible actually counts towards that $2,000. What is kind of important to realize about the way they wrote the law is they will allow that amount to go up over time, so to adjust for inflation. So we don't necessarily know what it's going to look like in 2026 yet, because we don't know what that dollar amount is going to be. So we can only tell you definitively what is for 2024 and what it's going to be for 2025. And as Danielle mentioned, passing a law is just the first step. Then we need regulations from the agencies who are actually implementing these laws to give us the details. And we're actually still waiting for some details. And one of the things that we're waiting for details about for next year is the Medicare prescription payment plan. In 2025, in addition to the drug costs being capped at $2,000, people will also be allowed to sign up for a payment plan, so that if you have a very expensive drug that you're taking in January, you don't have to actually pay that $2,000 in January. You can actually spread out that cost through this payment plan over the course of the year. So for example, instead of paying $2,000 in January, if you divide $2,000 by 12 months of the year, that's $167 a month. So that makes a very practical difference for people in how they're actually paying for their prescription drug costs. This is going to be open to anyone who has a Part D plan. And when we get to open enrollment in the fall for Medicare for next year, people can sign up proactively for this payment plan, but it is going to be something that's available to you throughout the year. Now, we are waiting on those final rules, which are supposed to come out this summer, that will tell us exactly how this is going to work in terms of when you go to the pharmacy and you find out that you have this expensive payment in January, can you sign up there? Do you have to call Medicare? So we're going to get more about the actual details this summer in those final rules. There were also some things that the Inflation Reduction Act did in 2023, which I just want to mention. It capped the copayment for a 30-day supply of insulin at $35 for Medicare specifically. And it also allowed certain vaccines that are covered under Part D to have a zero cost share. So there are some preventative services and vaccines like a flu shot, which are covered under Part B of Medicare, where you pay a zero cost share, meaning you don't pay a copayment and it doesn't get applied to your deductible. But there are some vaccines like the shingles vaccine where you have that coverage under Part D rather than Part B. And there are sometimes very high copayments to get access to those vaccines. So the IRA lowered the cost sharing to get those vaccines to $0, which was also very practically significant for people. I do want to mention that I called Part A and Part B original Medicare. But there is also Part C of Medicare, which are Medicare Advantage plans. These are private plans sold by insurance companies where you can go to one of those companies and say, I'd rather get my Medicare coverage through your Medicare Advantage plan. So you're getting the coverage of Part A and Part B through this Part C plan. And about 90% of Part C plans also include Part D plans. But if it doesn't, then you can go and also pick up a Part D plan. Now, I mentioned Part C plans because many people actually choose Part C plans. About 50% of people who have Medicare actually get their coverage through a Part C plan. And the interesting thing about Part C plans is that they create a lot of confusion for people because they are sold by private insurance companies and they're managed care plans, which means that you are choosing to get your Medicare coverage from a specific network of providers. So you lose that fee-for-service option to be able to go anywhere to a provider who takes Medicare. Here you have to go specifically to the providers through these Part C plans. The premiums for a Part C plan are going to be at least the same as your Part B plan coverage. So oftentimes on commercials, you'll hear things like, this is a $0 Part C plan, or they'll say it's a free Part C plan, which creates some confusion because it makes it sound like it's free, but it's not because you're paying at least the Part B premium to get access to the Part C plan. And so that's why the average premium for Part C plans are only $80.50, because that's $18.50 on top of the $174 of the Part B premium. The deductibles and copayments and coinsurance amounts are all going to be different based on the Part C plan that you pick. However, one of the benefits to Part C plans is that they have an out-of-pocket maximum for care under Part B, which Part B and original Medicare doesn't have. And the most that the out-of-pocket maximum can be for a Part C plan this year is $8,850. So this is a benefit where you're capping what you have to pay for any care under Part B. And that's a reason that many people choose Part C plans. If someone is in original Medicare and looking to cover those out-of-pocket costs, then they might decide that they want to buy a Medigap plan, which is also sold by a private insurance company and picks up the out-of-pocket costs for Part A and Part B. Now, if you want more information about your Medicare choices at Triage Cancer, we have a lot of resources to help you do that, as well as a webinar that we host every fall going into open enrollment so you can understand your options because you can make different decisions every single year. But then the question becomes, well, how do you offset some of these other costs, including paying for out-of-pocket prescription drugs? And there are a couple of different options based on your individual situation and your income level. So some people might be eligible for both Medicare and Medicaid. About 12 million people in the United States are currently what we call dual eligibles. meaning they are eligible for both programs. And in that case, Medicare pays first for care, and then Medicaid acts as a secondary insurance, and they're going to pick up the out-of-pocket costs under Part A and Part B, as well as Part D. And Medicaid often covers things that Medicare doesn't. So in some states, the Medicaid program offers dental care, for example, and Medicare doesn't do that. So it can sometimes be very beneficial for someone to actually be in both programs in terms of cost. For someone who doesn't qualify for Medicaid in their state, there are also what we call Medicare Savings Programs, or MSPs. And there's 4 different types of MSPs, and they have different income and resource requirements, and they pick up different cost shares, but they provide help for the out-of-pocket costs for Part A and Part B specifically. There are also options for picking up Part D costs. And the first is a program through Medicare called the Low Income Subsidy, or LIS, or Extra Help. So I don't know why there's so many names for a program, I think just to confuse us, but this is a good program to help you pick up out-of-pocket costs for Part D specifically. So this year, if you're having to meet the $3,333 or the $8,000, or next year when you're trying to meet your $2,000 out-of-pocket maximum, this program can actually help you do that. And anyone who has a household income level up to 150% of the federal poverty level can qualify for the low income subsidy. And this is actually a really underused program. Many people who actually qualify for this program don't know about it, and so they're paying more than they need to for their prescription drugs out of pocket. If someone doesn't qualify for the Extra Help program, there are also state-specific pharmaceutical assistance programs which provide premium assistance as well as prescription drug discounts on copays and deductibles. So every state's program is a little bit different, and it isn't available in every state. But if you visit Triage Cancer State Resources on our website, you can find the information for your state's program. I do just want to mention there's a couple of other places that you can go to for information about Medicare. Everyone who is on Medicare is supposed to receive the Medicare and You booklet, which seems a little daunting because it's thick, but it does have very information for Medicare beneficiaries. If you didn't get one in the mail, you can actually access or call and order one. But you can also actually call Medicare and ask questions. If you say agent, you can talk to a human being about the questions that you have for your Medicare coverage. There are also entities across the country in each state who have been given grants by Medicare to actually provide assistance. And these are called State Health Insurance Assistance Programs, or SHIP programs. What they're actually called in each state might even be different. So in Florida, it's the SHINE program. In California, it's called HICAP. So the actual local names might be different, but you can find their contact information on our state resources page as well. And then, as I mentioned, Triage Cancer has a lot of resources on Medicare to help you understand your annual choices when you're first eligible for Medicare, and how to access some of the savings programs that I've talked about today. And I will also mention one last thing about financial assistance to offset the cost of prescription drugs. There are clearly federal and state resources to do that, but there are many organizations at the local, state, county, community level that provide financial assistance in lots of different ways that can help you offset the cost of prescription drugs. And we always recommend that people talk to their healthcare teams about local resources to do that. But at Triage Cancer, we also collect some of that information and we share it on our Cancer Finances Toolkit. So if you go to cancerfinances.org and click on financial assistance resources, it is organized there by type of assistance. And we always encourage people to think broadly, because you might be looking for assistance with prescription drugs, drugs, but you might also qualify for utility assistance in your state. And so if you get utility assistance, then you can shift the dollars that you are paying for utilities to pay for some of those out-of-pocket prescription drug costs. So it sounds like common sense, but I think in the moment of a crisis and you're trying to figure out how to pay for things, sometimes people forget about those other solutions. And then the last thing that I want to mention is that we have a legal and financial navigation program at Triage Cancer, where you can contact us and meet with our team to ask questions about Medicare or health insurance or any of the other potential legal and practical issues that can come up after a diagnosis. And you can do that by filling out a form on our website. So with that, I think I'm going to turn it back over to Robin for questions.
All right, Joanna and Danielle, this was eye-opening and helpful, and especially regarding the importance of understanding about generic versus brand costs. I've got a question that's already lots and lots of questions that we're going to try to go through. We've got a good 15 minutes for this. So one of the questions that we had about the generic versus brand costs, let me get back up to that question, was regarding generic versus brand name drugs and max out-of-pocket expense. Some insurance companies are making generic the mandate. And so I can lead into this a little bit, Joanna. You and I had talked earlier that my husband has had myeloma for 24 years. And there are times when we've asked our doctor, are you able to write a prescription that says brand only? So I'm wondering if you could talk a little bit more about that.
Yeah, so insurance companies are allowed to choose their own formulary. And the formulary is the list of drugs that are covered by a particular plan. And some insurance companies are choosing generic drugs on their formulary because it's less expensive for the insurance company to pay for those generic drugs than a brand name drug. However, sometimes they are working with pharmacy benefit managers or other entities and negotiating discounts on brand name drugs so that they are choosing to include brand name drugs on their formularies rather than generics. Unfortunately, it is up to the insurance company to decide how they do this. And so there isn't a limitation on the insurance company on whether or not they're including generic or brand name drugs. So where there is a generic equivalent for a drug, really all you can do is ask for the brand name drug versus the generic drug if you're concerned about how that's going to help you meet that out-of-pocket maximum for prescription drugs under a Part D plan.
That's really helpful. Thank you. So the next question is, the neuropathy in my feet from myeloma treatment has gotten so bad that I can no longer safely drive. So my question is, does Medicare cover the purchase and installation of hand controls in a car when you cannot safely use that foot accelerator and brake?
That is a great question. I've actually never had that question. So I would want to look up that information in order to be able to give you a definitive answer. But that is also something that you can look up on Medicare's website because they do include all the benefits. What I would say is that there may be other programs that might cover the cost of adding hand controls besides health insurance coverage. So if, for example, just trying to think of a good one off the top of my head. If, for example, a person needs access to a car to drive to work, it might be a situation where you could apply for a grant from the Department of Rehabilitation in your state or a disability organization that provides those types of grants to make adjustments, and not just to your car, but maybe also to your home. So some states also have home modification grants, like through the Department of Housing. So there might be some resources out there, even if Medicare doesn't provide coverage. But if you want to contact us through our navigation program at Triage Cancer, that is absolutely something that we could look up for you and provide information.
That's so helpful. And I know so many of our patients and care partners have contacted Triage Cancer in the past. And so I would highly recommend that. So another question, the average premium for Medicare C Advantage is $1,850. How can AARP's plan, UHC, charge nothing per month and at the same time give each customer $40 each quarter to spend for over-the-counter products and free memberships to gyms?
Well, you have to remember, though, that that plan isn't charging $0. It's just charging $0 more than the Part B premium. And so they are charging you $174.70 this month at a minimum. And that's partly what they're using those funds to provide gym memberships. Now, interestingly, and without getting into too much of a policy discussion, Medicare Advantage plans were created to help reduce costs for the Medicare program overall. So that was the original thought process behind creating Medicare Advantage plans. But what we have learned over time is that Medicare Advantage plans actually cost the federal government 14% more than original Medicare. So the additional benefits that Medicare Advantage plans are providing, whether it's gym memberships or some of them are providing dental or vision care, someone is paying for that. So it might be you in an additional monthly premium. It might be coming out of your Part B premium. It might be coming from somewhere else in the Medicare system.
Okay, thank you. So when you own your own home and have saved for your retirement, how do your assets affect Medicare income determinations and eligibility levels?
That's a great question. So the income levels that are tied to Part B premiums and Part D premiums are just based on income. They're not looking at your resources or your assets at all. So it's just based on income. When you're looking at the Medicare savings programs, they're looking at both income and resources. So each type of Medicare savings program has a different limit for income and resource levels.
Okay. And I think this is a question for a clarification, but it's important. So if I'm getting a copay assistance grant, will that go towards my deductible? Just to drive that home.
If you are getting a grant, and not from a pharmaceutical company, if you are getting a grant from a private nonprofit organization, for example, and using that money to pay for your out-of-pocket costs for Medicare Part D prescription drugs, it will count towards that out-of-pocket maximum.
Okay, so that's good. That's helpful. Everybody should know that. So is there an interest charge to paying the $2,000 over 1 year in 2025?
That is a great question. Up until this point, all of the proposed rules have not included any interest payments. So that's not something that we're anticipating seeing come out of the final rule in this summer.
Okay. Are commercial plans, especially those on the exchange, expected to adhere to Part D out-of-pocket max?
So I think there's some clarification. So marketplace plans that are sold through the state health insurance marketplaces that are also referred to as exchanges, those are not Medicare plans. So Part D plans are not sold through state health insurance marketplaces. The $2,000 cap for Part D is specific to Medicare. Now, I will say there's been some conversations as we are in an election year about proposals to extend that type of out-of-pocket maximum to private insurance, like employer plans and individual plans like the ones sold through the state health insurance marketplaces. So that would be a significant difference in the way that health insurance is sold now. Which is also true for Medicare. This is a pretty significant change to Medicare, but we haven't seen it yet happen in private insurance.
So many good questions here coming in, Joanna, and I'm watching the time. We've got about almost 6 minutes left. So I see a question here about how is that income level determined?
It is based on the federal poverty level. So every year, the federal government determines what the federal poverty level is, and then it's a percentage of the federal poverty level. So at each percentage increase, it would increase your monthly premium.
Okay. So can I sign up for original Medicare and then later in the year, if I sign up for Part C, when I actually turn 65?
So I'm assuming that this is someone who has access to Medicare with connected to SSDI. And then when they turn 65, it's like you get a new entry into Medicare. So it restarts. So you can make different decisions about your Medicare coverage. And you can also decide to pick up a Medigap plan at that point too. So when someone is on Medicare due to a disability and they've been receiving SSDI, that's one thing. And then when they turn 65, they get a second chance to make changes. But someone who's on Medicare, generally every single year, has an opportunity to make changes to their Medicare coverage. And that happens during the annual open enrollment period, which is in the fall from October 15th to December 7th. But even if you make changes to your coverage on October 15th, they don't go into effect until January 1st of the next year, because you have to think of Medicare coverage like a calendar year plan. So it goes from January 1st to December 31st. So in open enrollment, you're making changes for what's going to happen starting in January.
Okay, there's a few questions here about people coming in to Medicare. So the first one is, what happens if you're in treatment under a private insurance plan, then turn 65 and switch to Medicare? Can they disallow coverage for specific drugs you're receiving?
When someone first becomes eligible for Medicare by turning 65, they're eligible for what's called an initial enrollment period, or an IEP. And that includes the 3 months before you turn 65, the month you turn 65, and 3 months after. But if you make your Medicare choices before the month you turn 65, those changes will start, or your Medicare coverage will start the first of the month that you turn 65. And that's really your opportunity to think broadly about how you want to access your Medicare coverage and get access to a Medigap plan if that's how you want to cover your out-of-pocket costs. Pre-existing conditions or drugs that you've been taking are not considered in terms of your ability to access Medicare coverage, including a Medigap plan. Once you're outside of that initial enrollment period, then your ability to get a Medigap plan without a pre-existing condition exclusion or paying more for that Medigap plan changes. And so, unfortunately, the health insurance protections that were in the Affordable Care Act around pre-existing conditions don't apply to Medigap plans. And so Medigap plans are allowed to take into consideration someone's pre-existing conditions. So as you decide to make Medicare choices, it's important to think ahead about what you might want or need for your coverage so that you don't lose out on some options down the road.
Okay, I'm going to try to summarize in the last couple of minutes and pick questions that are so helpful to as many as possible. So this one is about clinical trials. Does Medicare pay for clinical trial costs? So costs outside of the actual drug, but those other drugs that are added into the clinical trial?
Yes, so Medicare does cover the routine costs of care of participating in a clinical trial.
That's good. That's great. I love that answer. So if you have an Advantage plan, can you switch back to an original Medicare plan?
Yes. And the time that you can do that is during open enrollment. So we talk about Medicare coverage as like driving down 2 lanes. So you can go the original Medicare lane, or you can take the Medicare Advantage lane. And your ability to change lanes is during open enrollment each year. And then there are a lot of exceptions to the rules, which allow you to change lanes during the year. So if you have questions about this, I do actually really recommend that you watch that Medicare webinar that we have recorded on our website, and then we'll have one again in September going into open enrollment. So that can help you kind of understand the choices that you have available to you.
All right, I think that may wrap up the time we have for the open questions. But again, you've given us resources. This replay will be available. And I'm looking forward to going on Triage Cancer site as well. And so folks, don't forget that Joanna gave us a lot of good information. The replay will be available, as you see here, and I mentioned before, on myeloma.org. So we know just from this presentation and the amount of questions and engagement that's come in, this is certainly a topic for all of us to better understand. And Danielle and Joanna, you have been so helpful to something that is so complex. And we just thank you. And everyone, please utilize all these resources. Don't forget to call the info line because they can help. And then go to Triage Cancer website as well. So I wanted to just remind you that you are going to be having this little pop-up that's going to show for you to provide us with your feedback. As I said, it's so important. And if you don't have time now to do it, we will send you an email shortly after today's program so you can fill that out for us. And we've already talked here a little bit about the resources and wrapping up. So we have to thank our sponsors again, Bristol Myers Squibb, Johnson & Johnson, Karyopharm, and Sanofi. Without this support, we're just so grateful to bring these programs to you. And I just want to really, on behalf of the entire IMF, thanking everyone here today. We hope this was helpful to you, and especially Danielle and Joanna, your valuable information that's going to help us to live well, maybe financially as well as medically with myeloma. This has just been fantastic. So I wish you all a wonderful rest of your day. Thank you so much.